Frankovich. I'm a second-year rheumatology fellow from the University of Arizona, coming to you from RWCS. Here today I'm going to be talking about a case report. And so this is a 51-year-old female from the Philippines who has a history of CNS lymphoma that's on Pembrolizumab or Keytruda, which is an immune checkpoint inhibitor. She came to us with 3 months of subacute inflammatory monoarthritis of her left ankle that had been progressively getting worse. And she finally developed a fever, which is what prompted her to come into the emergency department that day. On initial evaluation, it looked she did meet SIRS criteria and it did appear to be septic with a very erythematous and indurated and swollen left ankle, but otherwise well appearing and hemodynamically stable. There was initial concern primarily for infection, so she was evaluated by podiatry and infectious disease. Their workup did reveal on MRI findings of osteomyelitis with a pretty large abscess in her calcaneus, which prompted them to take her to the OR. Surprisingly, upon incision and drainage, they did not find any abscess, no purulence. Instead, what they did find was a chalky white material that they thought was consistent with tophi. A few days later, her cultures remained negative. Her bone biopsy was not consistent with osteomyelitis, and that's how rheumatology got involved with the question of, could this be gout? On our initial evaluation, her symptoms had gotten significantly better following the IND. By clinical history, our suspicion for gout or other crystal arthropathy was very, very low. But because she was doing well, we agreed to discharge her home and follow up with her as an outpatient. The main thing on our differential at that point was a possible immune-related adverse event secondary to the Pembrolizumab, but we thought that the presentation was a little bit atypical. And then before she actually got to see us in clinic, she followed up with podiatry and had a repeat IND. That second bone biopsy did come back positive for acute osteomyelitis with granulomas in the tendon sample as well. And then about a week after that, her cultures from the initial IND came back and were positive for Mycobacterium tuberculosis. She followed up with ID, was given 3 months of RIPE therapy and then 6 months of rifampin and isoniazid, and last I checked is doing well. But this was a pretty fascinating case in the sense that TB still presents a significant diagnostic challenge because it's hard to culture. Interestingly, she was from the Philippines but had a negative PPD at the time of immigration to the United States. And 2 years prior, she had had a negative quant gold and a negative bronchoscopy with a negative AFB that was done as part of her CMV pneumonitis workup. The other interesting was the role what did pembrolizumab have anything to do with the reactivation of this TB in her ankle? Immune checkpoint inhibitors we often think of as immune activating rather than immunosuppressive, but I think the point is that we don't really know the downstream effects of these drugs yet. So it's possible we may be upregulating T cells, but downstream there may be an immunosuppressive component that I think needs to be followed. And yeah, thank you so much.